All right. Well, hello, everyone. Thank you for joining us today for our discussion and panel based on state-based reform. I'll be quickly introducing our guests before they start their presentations and followed by Q&As. So first, I'll introduce Dr. Mike Huntington. He is a retired doctor who specialized in radiation oncology before joining other physician activists in Oregon to advocate for healthcare reform. He went to school at OSU for undergraduate and then OHSU for his medical education, and then interned at the Madigan Hospital in Tacoma, Washington, and was an Army flight surgeon for 2 years. He is currently secretary of One Payor States, which is an advocacy group established in 2009, dedicated to pursuing comprehensive and guaranteed quality healthcare for all Americans. He will be helping with moderating our discussion today, and then with a little impromptu discussion as well with any specific questions for him afterwards. And then the next doctor on our panel, we have Dr. Chunhuei Chi, NPH, SED. He's a professor of the Global Health Program, the Health Management and Policy Program, and is the director of the Center for Global Health in the College of Public Health and Human Sciences at Oregon State University. He completed his NPH in International Health from the University of Texas School of Public Health, and his doctorates in science and health policy and management from the Harvard School of Public Health. In the 1990s, Dr. Chi worked with Dr. William Tsao in creating the Taiwanese universal healthcare system, and he goes to Taiwan every year to help in annual adjustments to their system. He currently serves in the Universal Health Plan Governance Board for Oregon, and he'll be giving the first presentation and Q&A before our break at around 2:22. And then our last guest today is Dr. Peter Arno, PhD. He is an economist and senior fellow and director of health policy research at the Political Economy Research Institute at the University of Massachusetts-Amherst, and is a senior fellow at the National Academy of Social Insurance. Dr. Arno received his doctorate in economics at the New School of Social Research and was a Pew postdoctoral fellow at the Institute for Health Policy Studies at UCSF. Recently, Dr. Arno's work has focused on economic analyses of universal healthcare proposals for the US, California, and New York. His 1992 book with Karen Fiden, Against the Odds, The Stories of AIDS Drug Development, Politics, and Profits, was nominated for a Pulitzer Prize. He will be giving the second presentation with a Q&A after our break. Now, I am in a unique position here as I'm an Oregonian that's attending med school in New York, which all of our guest lecturers can attest to one aspect of that or not. So personally, I'm very excited for these talks today. So please join me in welcoming our speakers about state-based reform, and feel free to take it away, Dr. Chi.
Okay. Good morning in the West Coast and good afternoon in the East Coast. It is a great pleasure for me to share with you some thoughts, some ideas about the Universal Healthcare Plan, particularly what Oregon is doing. So I'm going to start to share my screen, and I'm going to make about 30 minutes or so presentation, and then afterwards open up for discussion. Are you able to see my share screen?
Yes.
Okay. So in today's presentation, wait, let me see. I have some trouble advancing my slide. Are you able to see my next slide? Okay. So I have three brief sections. First short section, just briefly talk about the nature of a healthcare system. And then the main focus is on the second part, Oregon's path to universal healthcare. And then lastly, that's how we're imagining the healthcare system. By the way, as a disclaimer, as a member of the Oregon Universal Health Plan Governance Board, I cannot represent the board. So today, I'm speaking as a scholar in health policy and health system. But also, whatever I'm sharing with you about the Oregon Health Plan, our progress, they are all public information, and all the information can be downloaded from the website, as well as all our meetings are recorded and public. So one major issue when we perceive the healthcare system is, do we see healthcare system as an industry, or it's more than an industry, it's also a social institution? And this two different views will affect profoundly how we view our entire healthcare system. And WHO has identified 4 important functions of health systems: governance, resource generation, financing, service delivery. And you can see how those 4 functions are at the core of every state, including Oregon's planning to implement a universal health plan. Further, since the beginning of this century, WHO has introduced a major initiative to this day, is universal health coverage. And there's very rich information. If you go to WHO website on UHC or universal health coverage, you will get tons of references. And this next slide shows the 6 building blocks that contribute to a strengthened health system. And I specifically highlighted health financing and leadership and governance. One of my mentors, Professor Bob Evans from UBC, he succinctly summarized the 3 fundamental questions of health system finance: who pays, who gets, and who gets paid. So that's a quick overview of a health system. Next is the core of my presentation, talking about the Oregon's path to universal health care. So I developed this chart on the progress, and I highlighted the most recent legislation. But prior to 2019, there has been more than decade-long of advocacies, both at the ballot measure as well as the legislatures. So for example, in 2002, that was the first time Oregon put a ballot measure for a single-payer universal health plan to the voters. And I was involved in that ballot measure. And we knew back then with the planner, the organizers, we knew it's a long shot in 2002, but our main purpose was using that as an opportunity to prepare and to inform, to educate the Oregonians the importance of universal health care. So from 2002, the ballot measure, all the way to 2019, during that period, I was also invited to testify in front of the legislature 3 times why Oregon needs a universal health care plan. And finally, in 2019, the state legislature introduced and passed the first major piece of legislation, the Senate Bill 770. And a very important part of that Senate Bill 770 was to establish the Joint Task Force. And the Joint Task Force has the responsibility of designing and planning the detail of a proposed universal health plan. And so the task force started to work at the beginning of 2020, but of course we knew what happened in 2020, the pandemic. And so I was not in the task force, but I admire all the members in the task force that in the height of the pandemic, they were able to gather so much information and conducted so much research and surveys, etc. So they produced a very thick document, over 300 pages, that detail what this task force think will be the blueprint for the universal health plan. And so that whole plan, the SB 770 task force report, again, is a public information. You can search for that, and you can download the task force report. And the task force completed its work by the end of 2022. And that's when they produced this seminal report. And then came 2023. The Senate then passed the Senate Bill 1089. The Senate Bill 770 was very long, but contrast to that, Senate Bill 1089 has only 5 pages. And it's since the detail already discussed, introduced in 770, in the 1089, it focused on key principles. So for example, one of the key principles is this universal health plan should be a single payer system. And there will be a separate organization to organize that. And more specifically, the Senate Bill 1089 lay out the ground rule for the governance board. And the governor then nominated 9 members, including myself, of the governance board in January. And then we went through Senate hearing in February and got confirmed. And the governance board started to meet in April. So currently, the governance board meet every month on Thursday morning from 9 a.m. to 12 p.m. Pacific time. And anyone who is interested can register and to receive a link, can participate remotely. But then in addition, I will discuss a little bit more detail. We are beginning to develop work group and then committee. And I will share with you some of the work group. And the governance board have a deadline to complete a draft plan for the Universal Health Plan for Oregon by September 15 of 2026. So we were given about 2.5 years. And that's a very short time. I was involved in Taiwan's Universal Health Plan. And of course, Taiwan has a bigger population of 23 millions. And that whole plan took about 8 years. 8 years to plan that Universal Health Plan with two stages. And of course, we didn't start from scratch because the task force already did over 2 years of work to lay the ground and provided some important blueprint. And what happened after 2026, September 15, is when we presented our draft plan to the legislature. The Oregon legislature will review and approve it. And we anticipate, just like any legislation, it's highly unlikely they will approve as it is, as whatever we submitted. There surely will be a lot of debate, discussion, modification. And that's why I put the actual implementation year with 22X. That's hopefully still with the 22X, because there's uncertainty how long that process can take. More optimistically, the earliest would be 2027. And we are hoping it will be no later than 2028. So this is the process. And here are some of the key component and decision of a universal health systems. In terms of the governance, who makes key decisions, the process of decision making, and principle of priority setting. In terms of finance, taxations, and there are 2 sides of the finance, taxation and the payment system, how we pay providers. And the coverage question is a little bit more straightforward. Who shall be covered? That already laid out in the legislations. So we don't have to provide too much detail on the coverage because the legislatures already stated who will be covered. And then benefits and delivery, that's another complex issue. What service will be covered and which provider will be contracted? So these are just an outline because under each item, there are very complex issue, complex detail to be developed, to be discussed. And I'm also using the National Health Account Standard. In case some of you are not familiar with the term National Health Account, it's a system of both standardization and accounting that developed by the World Bank together with World Health Organization and with support from USAID and the CDA from Sweden. And the purpose of National Health, there are at least two purposes. One is serve the same function as the ICD code. The ICD code standardized the classification of diseases internationally, because before we had ICD code, even between high-income English country, US and UK, many of the disease name have the same name but different diagnosis, different definition. And that's how important is that the ICD code. And so the National Health Account served that purpose as well. It standardized all healthcare system and financing terminology. And the other purpose is encourage every country to produce National Health Account. And it's a detailed accounting of where does money come from and where does money go. And so wherever applicable, I will use the National Health Account terminology. So for example, in the National Health Account Standard financing mechanism, these are the key important method. And compared with that, the Oregon financing mechanism is primarily through the Universal Health Plan Trust Fund that work with state treasury. And then there's a term called financing agent. That's which institution will administer the financing. For Oregon, USP financing agent include two parts. The Oregon Universal Health Plan Governance Board serve as the supervisor of the financing agent. The actual financing agent is an independent public corporation, and the name is to be determined. But in the legislation 1089, it stated the financing agent will be an independent public corporation. And this is the result produced by the task force. So they identify up till 2022. In Oregon, this is an example hospital, how they receive differential payment from different payers, Medicare, Medicaid, Medicare Advantage, and then private medical insurance. And the single payer system will consolidate that and to have the identical payment so we consolidate all the source and to have the identical payment to all providers. And that alleviate the inequity of our payment system to providers. And then during our recent board meeting, we spent some time and even developed a work group to discuss the ethical foundation for Universal Health Plan. And I was one of the lead person to advocate that. And here I summarize why Universal Health Plan needs an ethical foundation. On the governance, so there's a series of questions. Who makes key decisions and the process of decision-making? On the finance side, how we define equity principle of the financial burden, also equity principle of the payment system to providers. On the coverage, who should be covered? And then on priority of health services, including what services should be covered and whose health condition should be covered, and whether and when to cover new technology. And some of you might remember, Oregon State was the first place in the world to apply an explicit priority setting mechanism for its Medicaid. And that took place between 1989 and 1992. And through that process, Oregon made a big contribution to both academic world and policy world. That is, up till that moment, all professional and academic and policymakers treated priority setting as some engineering or technical issues. But through Oregon's experience, we recognize no, priority setting is not a technical engineering issue. It's an ethical and political issue. And priority setting involves distributive justice, because all priority setting policy will generate distributive consequences, and it determines who lives, determines who gets health care. And so the ethical foundation is vital for making consistent and systematic decisions. And also the choice of an ethical principle is normative, so the process of choosing ethical principle matters. And my personal experience with Taiwan's universal healthcare is when it started, it skipped or neglected this step. So in the legislation and its national health insurance law, it did not explicitly state how priority setting should be carried. And that resulted in nearly 3 decades of political maneuver. And unfortunately, without a systematic principle, resulting in political maneuver is those groups with bigger voice get bigger share of the pie. And in our we have a value and principle work group. We met 4 times to develop a recommendation and brought it to the board. So we made 3 recommendations. I will not talk about detail. You can get this all from the Oregon Universal Health Plan Board. So the first recommendation is health equity statement. That is from the Oregon State's Health Equity Committee. So we unanimously decided to adopt this Health Equity Committee. But in that Equity Committee statement, there are still some important terms left undefined, which will become our task to define. For example, the common term equity is normative, and there can be multiple meaning and definition of equity, and we need to give an operational definition of what equity means. And the second recommendation is overarching principles. And again, each of those principles require a lot of work and details. Number 1 is maximize health, mainly population health of residents in Oregon. And second, fair distribution of medical resources. And again, we need to define what is fair distribution. And the third principle is minimize financial hardship from medical costs on individual and family. This is not exactly the same language, but a similar language was included in the Senate Bill 1089. We simply refine it. And then the last one is community ownership and governance. We decided that whatever the plan we develop, the community of all residents in Oregon should feel they have the ownership of this plan. This is not going to be a top-down plan. This will be a community joint effort and governance. And the last recommendation is how we defining fairness and equity. And our work group did not come with the conclusion. Instead, we come with the process. And so the process we propose is using citizens juries combined with targeted universalism. And again, you can find detail in the Oregon Universal Health Plan Board. They have documentation on those details. So this is the temporary timeline we are working. And starting this month, we are moved to phase 2, proposal development. Of course, this will be the longest effort. And we aim by the end of 2025, we will develop the first draft of the plan. And then that gives us 8.5 months or so to refine this plan. And in the Universal Health Plan, we have work plan and committees. During our most recent board meeting in June, the board concluded we are going to develop 4 committees. The first one is Communication and Community Engagement Committee. Second one is Finance and Revenue Committee. The third one is Plan Design and Expenditure Committee. And last one, Operation and Transition and Implementation Committee. Each committee will consist of at least 2 board members, plus, depending on the nature of committee, from a handful to over a dozen of experts that we invite to participate as a committee member. And so in July, the executive staffs, they're going to start recruit committee members based on the board members' recommendation. So this is the draft developed by the task force about the governing board. So the governing board has 2-stage function and responsibility. Prior to the implementation of the Universal Health Plan, the governance board's responsibility is to design, develop the Universal Health Plan. Once the Universal Health Plan is implemented, then the governance board will shift its gear to a different task, meaning supervising the financing agent, the public corporations who will administer the day-to-day operation of the Universal Health Plan. And so the governance board will supervise that, but the governance board will not directly involve in administering that, instead supervise that. And the 9-member governance board are nominated by the governor, except for the first group, because we want the member to be staggered, so you don't end up with all new members. So the first group of 9, we were appointed with different lengths of terms. The shortest is 1 year, and then there are 2 years, 3 years, and 4 years. But starting the next year's appointment, every member will be appointed at 4 years. And this also comes from the task force recommendations. This is a quick overview. And particularly, one important recommendation is the task force recommend no cost sharing. So that's very different from the current existing private health insurance. Finally, just briefly discuss how we're reimagining the healthcare system. WHO, in its Universal Health Coverage Initiative, also introduced the 3 general objectives of universal health coverage. And I also provided the link to WHO. First is equity in access to health services. And the second is the quality of health services should be good enough. And then last one, people should be protected against financial risk. And health system governance is the area I personally have profound interest and studied, researched over 1 decade. And the nature of health system and governance has profound impact. It determines who have access to healthcare, who makes the most important decision, who pays how much, who gets paid how much, governance structure and process, and who is accountable. And whenever I talk about universal health care, particularly in the US or any country who still don't have universal health care, I always like to remind the audience there's life after universal health care. There are different issues countries with universal health care have to address. So that, which is why the governance board will continue to operate after the implementation. So I summarized 2 dimensions of the challenge for the life after universal health care. The first dimension is political, and then I highlighted these are not an exhaustive list. I just highlighted some, I think, important one. And personally, I think the most challenging one is solidarity and sharing capacity, which commonly called sustainability. But sustainability has two dimensions. One is financial dimension that's attract most of the attention. But in many discussions on the sustainability, they neglected the political sustainability, which is solidarity and caring capacity. And of course, the issue of equity, efficiency, governance, imagination will be the political dimension, among many others. And then there's a technical dimension of the life after universal healthcare. Again, this is not a complete list, just a highlighted list. Important issues such as how do we maintain quality improvement, cost control, improving access and governance, health information technology, and other innovation, particularly the emerging use of AI. And improving access will be an important issue because one of the issues I brought up in the board discussion is we don't want to end up Oregon having universal health care, yet people living in some remote area or smaller town have no access to health care. And that will make the universal health care quite useless. And that's an important challenge we have to address. Finally, I share some quote from my mentors. One on the left by Bob Evans, he said, a common way of building support for change and neutralizing opposition is to present the normative statement as if it were positive. And then Professor Reinhardt said similarly in his last book, Price Out. He said, Americans typically shy away from an explicit statement on social ethics in debating health reform. Instead, that debate is couched mainly in terms of technical parameters. And this is the last slide, my final thought. This is also a quote from my other mentors, Governor Mooney. The question asking what sort of healthcare system do we as a community prefer is equivalent to ask what sort of community would we prefer to live in? And then my own reflection, a national health system tells us about the nature of its people. That concludes my presentation, and now we can open up for discussion. I saw survey. Yes.
Hi, thank you. That was a really interesting presentation. My question was, I wanted to hear about your experiences trying to implement universal healthcare in Taiwan, and like what are some of the kind of, if you could do like a bit of a comparative analysis of Oregon and Taiwan, that would be very interesting to hear.
Yes, as I mentioned, I review Taiwan's universal healthcare system and I periodically give recommendation to its reform.